Hello, in this video I'm going to be talking about your pathology report, or actually your pathology reports. A little bit about all the tests that are done if you have a surgical procedure or even just a biopsy, and all the things that you might see in your pathology report. Before I go on, I want to invite you to subscribe to our channel. We're always putting out new content every single week, so stuff you don't want to miss. If you subscribe, our videos will pop up in your feed. And don't forget to go to yerbba.com. You can get your personalized report. I'll be talking about that briefly in just a few minutes. You can follow us on Instagram, and I'll remind you at the end, you can put a comment or a question below. First, we'll start. What's a biopsy? A biopsy is when we take a piece of a cancer. So if you have a breast mass, we'll do a biopsy of that. Even if you have an area that's abnormal on the breast that you can't feel, it's just seen on mammogram, or there's something else that leads to a biopsy, even without a mass, we'll take a piece of that tissue. And that can tell us, in most cases, it's not always helpful, but a biopsy, if we see cancer cells, we can say this is cancer. It can be hard for us to say much more than that. It can be hard for us to say if this is invasive or non-invasive. So a biopsy is really just a yes, no, is it cancer? There are other parts of the body that we might biopsy. At the time you're diagnosed, or perhaps later down the road, you may have another area of your body where there's an abnormality. And a biopsy is maybe done of that part of your body to help understand, did the cancer spread or has the cancer come back? In general, these biopsies are really important. We might think somebody has cancer somewhere else, and without a biopsy, we're operating in the dark. Not all the tissues can be biopsied, but in general, a biopsy of a distant area is a really key part of the evaluation in people where we're concerned the cancer may have spread. Once we have a biopsy, especially if we're talking about the breast and the lymph nodes, we will generally, at some point, remove that whole area. We will generally remove the tumor or the area of abnormal cells. It might be after some initial treatment, and it may be as the first thing we do in treating the cancer, but at some point we take the tumor out. We know that without removing the tumor, people are much more likely to have the cancer come back, in particular with invasive cancer. There are some novel approaches being studied for people with non-invasive breast cancer, or DCIS, where the whole tumor may not be removed, but that's not the standard of care at this point. Once that whole tumor is removed, the pathologist, who is a specialized physician who can look under the microscope and look at the big specimen and tell us a lot more about that, the pathologist sort of takes over. And there are lots of things that happen to the tumor before it's looked at under the microscope. It's embedded in paraffin, or it might be frozen first and then embedded in paraffin, and then it's sliced, and then it's stained for all kinds of markers that we look for in the tumor. And those things can take longer than just how big is the tumor, what's the grade, is it invasive or not. So the first part of the pathology report will say, is this cancer? What type of cancer? Is it breast cancer? Is it invasive? Is it non-invasive? How do the cells form with one another? So is it a ductal cancer or a lobular cancer, or one of other types that are less common but also seen frequently, like mucinous carcinoma or papillary carcinoma, for example. So it will tell us those things, and then it will tell us what the tumor grade is. So how close do those cells look to normal tissue versus a little less organized or more disorganized. That's the grade, and we have a video we'll link to about grade of the tumor and what it means. And we can also see other things like our cancer cells invading into the normal blood vessels and lymphatics of the tissue around the tumor, the normal tissue. pathology report will tell you, are the margins clean? Did the surgeon get a normal rim of tissue around the cancer? So the cancer is removed, and then a normal rim, like a rind, if you think about the tumor like, we'll say a very, very small cantaloupe, and then there's a rind. Imagine the rind being the normal tissue. We like to get a normal rim if possible, and the pathologist will say, how much of a margin is there around the tumor? So that's just the original pathology report. The pathologist will also look at any removed lymph node and say whether cancer cells are present in the lymph nodes, and how many of those were sentinel lymph nodes, how many were non-sentinel lymph nodes. And you may see a numerator and denominator of lymph nodes. So let's say the pathologist says 0 lymph nodes out of 4, and that means 4 were removed and 0 have cancer. Or they might say 2 out of 6 lymph nodes, which means out of the 6 lymph nodes removed, 2 had cancer in them, and that means 4 didn't have cancer. So that's the first pass at the pathology report, and that's used along with information that your medical team has about you as a whole person to determine the stage. The pathologist can't actually tell you the stage of the cancer without knowing your physical, your whole being. So if you are coming in and you have aches and pains, and the tumor is in a lymph node above the clavicle, the pathologist won't necessarily know that, but your medical team will. So then everything's put together to determine what stage you have. The pathologist can tell you the tumor size, which is called the T stage, and the lymph node status and number of nodes, that's called the N stage. But they can't, not end stage, but N, as in letter N stage, but they can't tell you the M stage. That's for the rest of your medical team. So I mentioned pathology reports. What else might be in another report? So we can get the information about tumor size, lymph node status, the grade, and whether there's any tumor cells in the normal blood vessels and lymphatics. We can't get right away several other key things that we look at. So estrogen receptor and progesterone receptor are something else we look for, and the pathologist will often issue those in something called an addendum or an add-on that comes out after the other information is published and available in your record. And the HER2 status will also come out in even a third report or a second addendum, so a second add-on. So it's very possible that there are going to be multiple reports and that they come in at different times. If you see your medical team and not all of those results are in, that can be frustrating for you because those things determine what type of treatment you'll get. And it can be hard for your medical team because we feel like sort of something's stuck, we can't proceed. So we end up creating these decision trees. If this, then this. If this, then this. The other thing I want to say is if you go back for additional surgery, like the margin wasn't negative and you have another surgery on the breast, or 2 of 2 lymph nodes were removed when the sentinel nodes were taken out, you will possibly go back and have more of the lymph nodes taken under the armpit. Each of those procedures generates another report. One thing I just want to sort of as an aside is tell you that your Yerbba.com report can lay all these different procedures out and all the reports together and create sort of a one-page summary. It's very likely your medical team will do that as well, but not everybody can and not everybody has the time, or not everybody knows if that's helpful to you. So you can certainly ask to have everything put together, or if you have a Yerbba.com report, that's one of the advantages, is all your procedures will be listed and the results from each procedure, all in one report. There are a couple other things that'll be done to the tumor that come separately. So one is a genomic assay could be done, and we have a whole video on the Oncotype DX assay and another video on the other genomic tests that are done in people with breast cancer. So that will come separately from the company that does it. So that's not going to be from the pathology lab. That's a test we send part of the tumor out to have that done. And then there's another test that might be done that also may be in your medical record but is not done by the pathologist, and that's genetic testing. That's done by taking your own body's DNA, not the tumor's DNA, but it can be done through a blood test, usually a blood test, or sometimes we can swab the cheek, and that's a genetic test. So that's another test that might be part of your evaluation. If you have metastatic or advanced breast cancer that's spread to other parts of the body, there are a lot of other things that are tested for on the tumor that will be done, in special cases. So if you have stage 0 non-invasive breast cancer, also called DCIS, or stages 1, 2, or 3 breast cancer, these extra tests won't be done. But if you have stage 4 breast cancer, also called metastatic breast cancer, there are a bunch of other tests we will do on the tumor, and that could be done on the original tumor, or if a biopsy is done later, and when the cancer comes back, it can be done on that tissue as well. I've covered a lot in this video. I hope it's been helpful. If it has, click like and subscribe. That helps other people find this channel, and it will help you see other things that we produce. Drop a comment or a question below if any of this is confusing or you want to share your experience with the rest of the Yerbba community. Thank you for watching.